So this next speaker is one of my students, so I'm very happy to have him on stage. And when I say students, we're talking like a decade ago, I think, at this point, right? I think I'm going to age both of us here. I think it's been like a decade. But I'm very excited that it took me 10 years, but he's going to be speaking in front of this crew here. He's actually been a very good friend of the meetup community. His organizations has hosted the meetup for the meetup groups, for the workshops we've done. So before he even gets to the stage, a big round of applause for all the help he's done for the community too. And he loves to scuba dive, and his favorite place to dive is Costa Rica. And he has been face to face with a tiger shark. So you need to let us know, like, in reference, how big is a tiger shark? From this to Jaws, what are we talking about? So please welcome Jorge.
Today's talk will be about healthcare. Jared brought me in to give a little bit of background on some of the work I've done. I've been 10 years in healthcare, probably more than that, from graduate student to epidemiology PhD student, working on the hospital sides at Sloan Kettering, New York Presbyterian Hospital, the Columbia Cornell Medical Centers, and now my recent hat is as a payer at Aetna and CVS. What I wanted to talk about was to give some intuition on how we should be thinking about readmission predictions in the context of quality for hospitals. So the goal of this talk will be to give you not just so much like, hey, this is a state of the art, or here's the AOC curve on good models, but really like when are they useful and how we should be thinking about pairing a prediction with an intervention. Because I think I start here with this slide, which is to say, us in bioinformatics, the statistics or data science phase, we like to create models and create complexity to try to solve and get an interesting segmentation or stratification or identification. But at the end of the day, we're not going to be doing the clinical work. It's in this space, in this picture, which is the provider and the patient, that you kind of want to be invisible. You don't want to be in there, but you want to help inform and give enough tools, or all the information necessary for the provider to act, to respond, and to prevent. So that's sort of the space that I want to discuss. But before we discuss on how to intervene, I think it behooves us to understand what are the contexts. Why do we care about hospital reduction readmissions? Where did this come from? So I start with a little bit of context, and then we'll jump into state of the art and how some organizations and groups are thinking about it. Okay, so I think everyone saw this mainly from the abstract for the talk. So context, outcomes, population, timing of modeling, and then interventions, right? So that's sort of the flow. So let's hit it. Okay, so this first one. If you go to this website, www.medicare.gov, Care Compare at the bottom, you'll find that CMS, Centers for Medicaid and Medicare, right? So this is government and student. So CMS has done an amazing job over the past decade of putting together what is a tool to give patients insight, to give whether you're looking for a doctor, a hospital, a nursing home for an elderly parent, hospice care, anything, basically most of the facilities that you search for care at, CMS has done this tremendous job of putting together a view for someone who's not clinical to very quickly surface, hey, which of these providers, which of these hospitals gives me superior care for an efficient cost. So this notion of value is something that CMS started more than a decade ago, passed through the quote unquote Obamacare. But even before that, it was a lot of wrangling and data collection, getting to a framework where you can actually, I would say, force hospitals to give this data such that we can put together a national vision and a tool like this. So it's no small feat, very political, very technical, but we're here. So you go to this website, and then I can search for a hospital. Say I'm looking for an acute care hospital for, let's do knee and hip. And I'm here in New York, and lo and behold, in the same grid, less than 2 miles, 3 miles away from each other, there's two hospitals. This is public, so I'm not calling out names. Elmhurst Hospital Center, and then Hospitals for Special Surgery. And what we see here is an incredible summarization and quick jump into, hey, this is a good or bad quality hospital. And hey, the patient satisfaction scores, surveys that are run on our patients can represent the level of care you're expected to receive quality-wise, and then the hospital, the care services that you'll receive as a patient, your experience of being in there. And this is pretty jarring that you can have two hospitals so different, so close to each other in New York City. But that's the true nature of the healthcare system. A lot of differences in care, a lot of imbalances in resources, and you, as a patient or as a care, as a someone who takes care of someone who's sick or is fighting disease, these tools are here for us. And then in this, part of this whole system is one of these measures, one of these subcomponents that I'm going to talk about, which is the hospital readmission measure. That goes into the START notion that says, hey, if you're treated here, you'll likely be taken care of well inpatient, and you'll likely be connected to a system that'll carry you through to get you safely and back to your daily life activities, right? So this is sort of the motivation. And again, how do we get there? And what am I really talking about, right? So on the left-hand side is this whole milieu of measures. Each one of these measures has incredible validation and two retrospective studies to demonstrate that the measure is stable, that it can be reproduced, and it's all through the National Quality Foundation. I show maybe like 23 measures here. They have a catalog of over 1,000, and they're constantly adding. It's a big area of research. And what I'm calling out here is really these three types: readmission rate, acute myocardial infarction; readmission rate, heart failure; readmission rate, pneumonia. But you see that there's many measures that get publicly reported, and specifically for the subset of readmission measures, what goes into this, the secret sauce for this measure, is first the data collection. So you have more than 3,000 hospitals nationally pushing data in on a quarterly basis, being assessed, being collected. That's where taxpayer dollars go when they go to Medicare. I mean, this is really difficult work to manage this whole process. But then once you get into this phase where, okay, I've collected the readmissions using standardized ingestion protocols, then we move to the next phase. And this is where CMS, I believe they contracted with Yale to do this. They take this and they start making inference over this data, right? And I'll go into this in a second. But the idea is you create a hierarchical model with all the hospitals and patients nested in the hospital. And then we collect features that are risk adjustment, they call case mix adjustment for more complex patient, less complex patients. And then we were able to rank the hospitals. We were able to compare the performance from the very honorable or lofty Mayo clinics or Hopkins down to the community hospitals in Idaho, right? They're all put on the same standard, and we try to or CMS tries to drive and it constantly increase performance. So you have the modeling, you have a standardization such that they're comparable, then you get these distributions for risk ratios to say at 30 days, medicine, surgical, overall, how is your hospital performing? And what CMS does is they draw a line. Line's not here, but they draw a line. They say, if you're on this side of the curve, well, you need to improve. And what they do is they apply a penalty which is 1%. And that motivates, right? So when you're hitting the bottom line, that definitely causes motivation for hospitals to enact processes, to enact procedures, to deploy analytics teams, to roll out predictions that they can do something with in order to improve the performance, not be on the outlier side, right? But the way this is structured, everyone's trying to improve. All the hospitals always, because there's always going to be someone on the right hand of that curve. But the implications are much more profound than the so-called penalization or financial push to improve quality. In fact, what happens is this now becomes public. So that same website that I showed you, I'm making decisions not to go to this hospital if I can go to this other hospital. Some cases you don't have that. Hospitals are monopolies in some regions, like they have one system. But if you can choose, you choose. You can definitely choose at the provider level. So there's public reporting. New York Times write an article about you if something's really awry. Then this links to reimbursement, but also commercial payers, private payers have followed suit. The big expression is CMS is the gorilla in the room. Whatever they do, sort of they suck the air out, and all the other payers are like, well, let's do that. And in this case, CMS paved the road in order to drive this big quality, value-driven care initiative, because this gets pushback. But they can demand this because they cover so many lives. So because of this, private payers ensue. And then the whole notion here is that there's a lot of incentives if you're a good performing system, good performing hospital. And then if you're a good hospital system with good measures, well, then you also attract a lot of the talent. So this is sort of the thinking and how it goes. And does it have an impact? Yeah, definitely does have an impact. So this is in 2020. This is the Kaiser Permanente Health Network. Basically, half the hospitals received some level of penalty. And just to give you context, a hospital like New York Presbyterian would probably have 600 million, might be more now, might be like 900 million in dollars from Medicare. So you're getting a 1% hit annually. You're looking at somewhere between $6 to $9 million penalty, and that could wipe out the margin for a month, right? So you don't want to be there. It does hurt financially, and there's this push. However, right, or let's just say that the fairness aspect of this is important, right? I'll just say that sometimes small hospitals have a hard time doing this, right, because they don't have the funding. And then the question becomes, well, do we penalize them on top of it? They're already underfunded. That's why they're not performing well. So the push has been to sort of understand how to correctly adjust and what are the right sort of course matching levels of hospitals that should be compared to do this benchmark distribution and assess a penalty. So that's sort of the conversation. Okay, and then I believe this is my last context slide. And then what we think about is that there's this whole flow of care, right? So when you're home and you're at the gym, all the way on the left-hand side, you have no acuity. Maybe you start developing some comorbidities, hypertension, diabetes, see your doctor. Maybe you have a condition that keeps escalating, and eventually you're in the ED in the hospital, right? The correct path is then to go to rehabilitation if it was a surgical procedure, go outpatient, get out of the center, get at home, or maybe you're permanently going to need some help long term. This is this flow, but the idea is to return you back to health, to your activities. And in the general situation, this is the way it goes, right, for the vast majority. But as you age, as you get older, or you have a chronic disease, sometimes that's not the case. Sometimes you start seeing this recidivism back into the hospital. So instead of going all the way back to home, you jump back in. This is the notion of the readmission. But not all of these are preventable or avoidable. Sometimes you reach the end of medicine, so you're not going to have the ability to jump back. So again, the idea is to create an avoidable 30-day readmission. This is little schematics, but the idea is that if you're admitted, let's create an inclusion criteria where we can split you up into surgery, cardiovascular, these different cohorts. And then we assess an outcome. And then the outcome, there are certain things that might be planned for that index event, your hospitalized index event. And then these are the things that you don't want to penalize for, but you follow post-discharge 30 days, and then you assess if a hospital has 1,000 patients, 30 of them came back, what's the rate? How does this compare to other hospitals that had 1,000 patients, right? So this is just defining the outcome. There's an exclusion. There's a set of ICD-10 codes. I'll talk about that one second. That will say if you're readmitted because of one of these, it was planned. They're scoping you. You're getting follow-up care. It's a good thing you're back. You're going to have a surgery procedure that's going to prevent the next one. So it's not always bad. It's only if it's avoidable, and there's good structure around that. And then the intuition here is that what you want to do is you want to identify the patients that have this risk, that because of the milieu of conditions of comorbidities or context at home, that you can do something. Hospitals have the largest budget in the community. There's many clinical organizations in the community. Hospitals, the biggest budget. They have the most money to do something and organize and partner. So that's why it makes sense to use hospital as a center to base these programs. The idea here is if you have no strategy, then basically you have some at-risk people you don't know, and you're getting penalized. It's costing you money. Private and government payers will not pay for some of it or penalize you. So and it's costing you money, right? You're not putting in maybe much more lucrative procedures, and you have a readmission for a sick patient that's not reimbursable. So there's motivation all throughout to fix this, to act on this. So the idea here is then, let's not differentiate the population, and let's just swab and prevent infections in the hospital, generalized, and then that should reduce by some level, right? So you drop off 2 patients, some level of benefit is observed. The idea here is that maybe some people didn't need this intervention, right? Or you're spending money, or you're not spending enough money in some groups to prevent it. So this is, lo and behold, where risk profile patients come in. And this is the notion of readmission, that this is now denoted by different colors. If you're really sick, you kind of want a differentiated intervention, and this is what predictive modeling in the inpatient setting lets you do. It says these people will be fine. These second people, if you intervene a certain way, you'll reduce. If you intervene another way for the most at risk, you'll reduce, but you'll never reduce it to 0. So there, it's just the nature of medicine. Some people, it is quote unquote their time, but this is the underlying intuition. And as you benchmark, and then now as you create predictions to segment and treat differently, you want to take account into the differences of the individuals, right? So how do we do this, right? How do we cut out the populations that matter? First, what are the populations? This is a quick snapshot of a report that a hospital would get from CMS. A lot of information. I just want it to be in the deck so you can see it later. But a hospital will get this report for myocardial, that's heart attack, COPD, heart failure, pneumonia, CABG, and total hip knee and hip and knee replacement. So these 2 are surgical procedures that should not have a readmission, and then you should be able to manage these 4 conditions very well such that they're not readmitted. So this is fair game, what's been allowed in the rule books right now. And then you get this modeling of what is your predicted, what is your expected, and what's this excess amount. This is the foundation of how you're going to be judged on the benchmark, and how CMS is doing it now. How do they get this predicted readmission? You're in this modeling framework, right? So you create a generalized linear model. So I know there's statistical teams here, but the gist here is that you have a matrix of information here, the BZI-J, which is hospital J and patient's I, and you're going to adjust for comorbidities, so conditions that would also drive the individual patient to be readmitted, and then you fit a random effect for a hospital. And this data and these risk adjustment factors are very important to differentiate. This hospital treats sicker patients than that hospital. So when we compare, we need to give hospitals credit for the care that they give. And that's the idea why we do this model. And then we fit the random intercept for a hospital effect. We don't have, they don't include hospital characteristics per se in this model. But we get the patient characteristics, but we do allow for random intercept. And then we do an indirect standardization such that we get apples to apples comparison, right? So this is sort of behind the scene what CMS is doing. And the features, an example of the features, they're based on ICD-10 codes, right? So here's endocrine metabolic disorder. This is a mapping from ICD-10 codes, diagnosis codes, into this grouper, this aggregate mapper that maps codes to an ontology that we put in a binary feature, and then it fits into this hierarchical model. So this thing increases risk of readmission, right? Basically, they all increase risk. We're not modeling preventative effects. This is all from methodology from CMS papers. So, and then I'll say that more or less the C statistic on these models is around 75. So a lot of the times when we talk about modeling here, and I'll show you now, even as we get more advanced, you're not beating this readmission prediction at 30 days, more than 70, 75, 80 max that I've seen for area under the curve of C statistics, because a lot of what happens, half the battle, or literally 25% of the battle, doesn't happen in the inpatient setting. It happens with the connection post, right? Because you have 30 days where people are on their own. But a lot of it is controlled by the inpatient setting, that 75%, but a lot is not, right? So this is the world that we live in. Hospitals have the mandate to intervene and have budgets to intervene. So then that becomes a question, how do we pull this all together? So now, just to give you a quick notion of, I have timing on top, but the idea is now that this is a standard type of readmission prevention or readmission prediction paper that a hospital group would pull out. This is Will Cornell, a lot of different groups that put this together. Now, instead of just claims, you're using electronic health records. So this is labs and medical notes and a rich assessment of other data. And what they do is at discharge, or at admission, you know something, at discharge, you know a bit about the individual, and you create different types of ensemble models to try to predict what, what is the risk of this patient in terms of coming back in. I believe this is what we're looking at, 3,000 or so patients. Okay. And so what you get is this, right? So this is a 30-day model, so readmission at 30 days. This is heart failure cohort, around 3,000 and change patients. This is outcome at readmission at 6 months. And the idea here is you have slices of data at the index. So when you're admitted, you know some information, some red blood cell measure, some hemoglobin measure. Then at discharge, you've treated the patient, now you have a delta, you have a final state. You can aggregate the features, take means, take exponential smoothers, you can do many, many, many different things. And then you started saying, okay, well, this measured here, now I can predict. And then again, you're still looking at, different information at different time points, but it's not great. It's not really good classification by any means. It could be improved, but this is the state of affairs in terms of how we can predict. Let me see where we're at. Yeah. So this is how we can predict and get at the risk. If I tell you that cutting edge this was the Google deep learning paper, 2008. So they use billions of, I believe, 1 billion discharges from different medical systems. And they're also looking at this, more or less 77, 76% readmission prediction capability. But so then where's the secret sauce, right? I think it's this, and this is what I want to leave you with, right? This is a mediation framework. And then the idea here is that as we start looking at what is your risk of an event, you also want to look at the context. So this is in this framework of, you have geography. This is the risk adjustment factors, demographics, the per member per month spend, utilization prior to an event. But then we want to look at what are the contexts, right? What are the standard of social determinants of health? Are there barriers that you cannot, that the patient themselves can't overcome? Well, if so, then let's intervene. Let's give them money for an Uber, right? Let's get them some discounted medication so they can improve adherence, right? There are many things that let's get a hospital to their home and pay for it because it will likely be cheaper. So just to give you context, I think this is where most of the hospitals, most of the providers are now considering, is to say, let's take this environment and let's turn it into causal framework. And let's start experiencing, given a risk score, how much can we mediate through one of their elements that would reduce impactability. And then this is area where research is ongoing. What are the right interventions, piloting different interventions. And you'll find that a lot of hospitals who have assumed more of their risk start thinking and saying, let's spend some more than what we normally do, because if we intervene on these mediating pathways of risk, then we can have an impact to reduce readmission, to reduce mortality, to connect. And a lot of these are a further connection with partners in the community, right? So I think this is where we go. That's the message I want to land on. And then, of course, doctors, like anything that can help them save money. And then finally, I'll say a lot of tools have been implemented, right? You have to think about the system to intervene on in order to drive change and do impact. I challenge you to read this article. A lot of innovation in AI for COVID didn't really help. So how can we be more helpful, and how can we facilitate that relationship between the provider and the patient? I'll stop there. I hope I sparked some curiosity to read more. Thank you, everyone.